Hello everyone, how are you? This is Yazan Abukweder. I'm a clinical oncology pharmacist. Today I want to talk about the management of neutropenic cancer patients and the dilemma in practice between when to give prophylaxis and when to treat febrile neutropenia. So first of all, cancer patients are at risk of bacterial infection, bacterial gram-positive and gram-negative microorganisms. So what is febrile neutropenia? Febrile neutropenia is defined as a patient who has fever of a single oral temperature of at least 38.3 Celsius or an oral temperature of at least 38 Celsius for more than 1 hour. Regarding neutropenia, which is calculated through the ANC, the absolute neutrophil count, defined as having a neutrophil count of less than 500 cells per microliter, or a patient who has a neutrophil count of less than 500 cells per microliter during the next 48 hours. Regarding the prophylaxis, no guidelines tells you what to do. This is center-specific decision. There are two criteria to give prophylaxis. The first one is profound neutropenia, defined as ANC count of less than 100, or a patient with anticipated prolonged neutropenia. The anti-pseudomonal fluoroquinolone, either levofloxacin, which is preferred because it has a good gram-positive activity. The second option is ciprofloxacin because of its limited gram-positive activity. For the management or the treatment of febrile neutropenic cancer patient, monotherapy, anti-pseudomonal beta-lactam. Our options are piperacillin tazobactam, cefepime and ceftazidime, not frequently used because of they have no gram-positive activity. And the third option is meropenem or imipenem, and these are good options for the ESBL-producing microorganisms. If I have a patient with type 1 hypersensitivity penicillin allergy, I go with ciprofloxacin or estrinam plus vancomycin. Duration of therapy is at least 14 days and ANC count of more than 500 cells per meter square, whichever is later.